Well, our first discussant will be Darcy Ploucha, who will speak on the therapeutic journey of protocol management in the treatment area of the Hillman. Darcy, take it away.
Good morning, everyone. Let me just share my screen really quickly here. All right, so as Dr. Kirkwood said, my name is Darcy. I'm one of the PAs that works with the protocol patients for the melanoma program with us. I started with Dr. Kirkwood's team about 6.5 years ago. So I have been going through many different trials, and my position's a little bit different. So I always like to kind of introduce myself here and let everybody know about me, because you won't see me in clinic. So I am based in the treatment room, and all of our patients that are receiving IV infusions or special labs in the treatment room, they usually see me before the treatment starts. So what I want to go over is what to expect on your treatment day. Things are a little bit different for protocol patients versus standard of care, meaning if you're not on a clinical trial. So if you're on a standard of care treatment first, and then you go over to a clinical trial, things look a little different. So I just want to review that with you. In our specific facility, the patients who are receiving labs, instead of going to a phlebotomy, you're going to come back to the treatment room and go to your research chair. And that's where you'll spend most of your day. I will see you back there and do the physical exam. We'll go over AEs, which is adverse events, and we'll go over that a little bit more today. And then we'll talk about pharmacy and drug administration, as well as possible observations, vitals, and labs that patients on clinical trials may need. So that's already the first step that looks different. You don't go to phlebotomy and then to the clinic. You just come to the research chair and you spend your day there. So let's talk about the pharmacy a little bit. And this kind of includes standard of care patients as well. It's not specific just to the protocol patients. So our infusions are prepared by the general pharmacy that staffs the entire building. We also have a separate, what's called IDS, or Investigational Drug Service Pharmacy, that prepares any oral study medication. So if you're on a clinical trial that is combining an oral medication with an IV medication, your drugs actually go to 2 separate pharmacies. They go to the regular one for the infusion, the IV part, and then it goes to IDS for the oral part. And usually your CRCs, your research coordinators, will bring you your pills from the IDS pharmacy. Additionally, when you start a study with pills, you'll meet one of the IDS pharmacists who will actually go over your drug administration, storage, whether or not to take it with food or on an empty stomach, as well as what to do if you miss a pill. So you're being seen by multiple people to go over these things with you. So something that's really important to remember is that these days can be long. You have to have all of your labs resulted. You have to be seen by a provider if needed, which most of our studies do require that for every visit. Then the orders are signed, which usually I can do. If it's a cycle 1 treatment, meaning your very first day, then that has to be signed by one of the MDs. Once the orders are signed, you have 2 separate nurses, so your treating nurse plus another one on the floor, that are going to review your medications and your orders, your labs, and make sure everything is appropriate and safe. And then they send it to pharmacy. Once it gets sent to the pharmacy, you are going to have 2 separate pharmacists that are going to check it as well. And then they start mixing. So for patients who have medications that need to be thawed, the mixing doesn't actually start until those 2 checks are complete. And when I say mixing for the drugs that need to be thawed, what I mean is they're not taken out of the freezer until we know for sure that you're getting it. So that definitely adds a lot of time to your day. But we always want to make sure that it's safe for you to get this. So you have lots of people checking to make sure that is the case. So now I just want to go over some AEs, adverse events. So an adverse event is anything associated with the use of drug in humans, whether or not it's considered drug related. So this can include lab abnormalities, subjective complaints such as fatigue or pain, objective exam findings such as wheezing in the lungs, or certain findings on imaging. So examples of that would be pneumonitis, which is an inflammation in the lungs, or hypophysitis, which is an inflammation of the pituitary gland that sits in front of your brain. So those are things that we see on imaging. So the reason this is important is when you are part of a clinical trial, we use this information to determine whether or not, or I'm sorry, to include on potential drug packet information. That's why when you see all these commercials for drugs on TV and it lists 1,000 things, you know, anything that the patients complain of while they're on trial gets documented. The CRCs, the research coordinators, write this information down every time you're here. They go through your labs, and then they give it to me or to Melissa or Chris or the MDs, and we go through and we write whether or not we feel that this is related to your drug or not. And that helps us make that information that's available to the providers and patients when the drugs are approved. So it's definitely can be a time-consuming process, but it's really important, you know, for safety and future use of these drugs. So every AE that we have is graded. So we use the CTCAE grading scale. This is old. It's actually version 4. We're on to version 5 now. But this just gives you a little bit of an example of what we're looking for. So for example, anemia is a lab finding of low hemoglobin. So it'll tell you a grade 1 is going to be low to 10, a grade 2 is 8 to 10, a grade 3 is less than 8. So typically, if things are grade 3 or more, that's when we a lot of times have to consider holding treatment. Now, with that being said, every protocol is different. So anytime I see a lab value or have a patient complain of something that's new, I will go look it up in your protocol and make sure what that protocol specifies about how we manage that. So for example, I have some protocols that if your liver functions are a grade 1, so that means slightly elevated, we hold your treatment. And then I have other protocols that don't require that until they're a grade 2. So everyone is different, and this is something that I review on a daily basis. And anytime we see these changes, we review the protocol and make sure that we're treating you, you know, the safest way possible and how the sponsors of the protocol recommend. So just to go over this chart a little bit more, neutropenia is low neutrophils, part of your white blood cells. And then thrombocytopenia is low platelets. So we use that as well for grading. And like I said, I actually have an app on my phone. When I started here, I had a huge book that had everything listed. And they're always making changes to that and updating it. So you can see at the bottom here, the version 4.03 was June 2010. And then last year we started with version 5. So just to quickly go over some adverse events that we see with immunotherapies. I always tell patients when they start, this can affect any organ system in the body. So we always want to keep that in mind. And even if it's not something that I reviewed with you, you should still be reporting it. And so we can evaluate it. So constitutional mild fatigue is normal. Skin, itching, rashes, blistering, peeling, vitiligo, which is that depigmentation, or poliosis, which is the depigmentation of the hair follicles. And the gut diarrhea is common and important to always tell us if you're having any new diarrhea or dark tarry stools or blood or mucus in your stools, cramping. In the lungs, we can see that pneumonitis that I mentioned earlier, which is inflammation in the lungs, and that can present as shortness of breath, new or worsening cough. We can see hypoxia, meaning your oxygen levels are low when you come into treatment, or tachycardia, meaning your heart rate is fast when you come into treatment. Back to the liver. A lot of times I honestly don't see a lot of symptoms with the liver functions. However, you can have nausea or vomiting, right-sided abdominal pain, dark urine, or yellowing of the skin or eyes, like jaundice. And then the endocrine is fairly common as well. So thyroid, pituitary gland, adrenal glands. If those are being affected, they can cause fatigue, weight changes, heat or cold intolerance, constipation, headaches, weakness, hair loss, rapid heartbeat, increased sweating. So obviously this slide alone is a lot of information. So that's why I always tell us, if you're having any new symptoms, we'd rather you call, even if it's not something that I reviewed with you or one of the other providers reviewed with you. It's still something we want to know about. And then here are some other things that are less common. Eye pain, we can have dry eyes. The heart can be affected sometimes. We can have types of anemia. We can have muscles or joint pains, pancreatitis. A lot of times we see asymptomatic increase in the pancreatic enzymes, which is just amylase and lipase, meaning you don't have symptoms from it. We just see that on your labs. And then kidneys can rarely be affected as well. So really quickly, I know I'm running low on time. The management of the AEs, again, like I said, it depends on how severe they are. And we use that grading scale to help us and keep it routine throughout institutions. Sometimes if they're bad enough, we will have to give a steroid taper. And again, that is referral to the protocol, discussion with the team. And then a lot of times we can resume treatment after it's recovered to a grade 0 or 1, again, depending on the protocol and how you do with the steroid taper. Also really important to remember that immunosuppressive agents don't appear to affect your response to therapy. So having to hold and do this taper doesn't mean that your treatment is no longer going to work. And then really quickly, I have a couple pictures. So this pneumonitis, you can see on the left, the normal CT scan of the lung. And then on the right is this, this hazy stuff here is pneumonitis in a patient on immunotherapy. And then a couple different types of rashes. Maculopapular is flat or slightly elevated, these red rashes. And then you can see here a bullous, meaning that little fluid-filled vesicle here. And then these are more of a picture of psoriasis, so these flat patches that can be scaly. And here's a picture of vitiligo and poliosis and more vitiligo. So that's a more common presentation.
Thank you so much, Darcy.